So that brings us up a little bit closer to the present, where we can think now about the HCR-20 and how it was trying to harness that kind of approach, that prevention paradigm, and it was trying to structure all the different aspects of that task, the different elements of the task of violence risk assessment. And what I would say is, I think if we look back, we can acknowledge to ourselves that versions 1 and 2 of the HCR-20 did an okay job, but not good enough for us. And we're going to say this right now, version 3, still not good enough, but it's getting better. And what we've been trying to do is to structure more and more of the decision-making process, not to take discretion away from evaluators, not to stop them from using their skills and abilities and talents, but to help them use them better, right? So the whole point of this manual is to try to help us use the same kind of prudence and have the same kind of good practice that Sully did when he was landing at A320 in the Hudson River in New York. So let's talk a little bit about what this version 3 is going to look like. Now, for those of you who've been using version 2 and who've done training over the last, say, 5 to 10 years, you'll have seen some of these elements that we've been working on. What we've been trying to do is to take general developments in the structured professional judgment approach and build them into the HCR-20. The HCR-20 is going to reflect, and in fact, it's going to epitomize best practice with respect to structured professional judgment guidelines. Many of the elements of guidelines that have come out since version 2 was published, that is, say, in the last 16 years or so, will be incorporated in version 3. And so we really owe a debt to the people who've been working on the development of other structured professional judgment guidelines over the last 16 years, who were in turn inspired by version 1 and 2 of the HCR-20. And again, we could trace this all back to probably Chris Webster in 1993. So it's a pity Chris wasn't able to be with us today, but we are remembering him and thinking kindly of him today. Version 3 of the HCR-20 is intended for a comprehensive, dynamic, management-oriented assessment of risk for institutional and community violence. So really, no change in the scope of the manual. It is designed for use with males or females, and there's a good evidence base supporting the use of the HCR-20 with both genders. Designed for people who are age 18 and older, has been used in several studies with people who are 16 and 17. Not a problem there, especially if they're people who are functioning as if they're adults, but it's really designed on the basis of the adult literature, so we say age 18 and older. Two really important things that we want to clarify. It's regardless of one's history of violence. You don't have to have a history of violence in order to be assessed with the HCR-20. Violence risk assessment that only looks at recidivistic violence is a little bit useless. It's kind of saying, are you going to have more problems or problems again? And it was never our intent to limit the use of the HCR-20 just to people with a history of violence, although we always recognize that it's much easier to do a violence risk assessment when there is a history of violence. There's more data to work with. There's more information. But in many instances, especially nowadays, we see that people are being asked to do violence risk assessments in workplace settings with somebody who has no known history of violence. Or police who are using the HCR-20 have to do a violence risk assessment in a case where somebody has not yet committed violence. So we may be looking at assessing risk for first serious violence. We think the HCR-20 is appropriate for that. And similarly, the HCR-20 is intended to be used with people regardless of their personal history of mental disorder. The HCR-20 assumes that mental disorder in the form of major mental illness, or major mental disorder as we call it now, personality disorder and substance use disorders, that all three of those forms of mental abnormality are risk factors for violence on average, but they may or may not be present in an individual case, and they may or may not be relevant in an individual case. But we always have to look for them. But even if you're doing an evaluation of somebody who has no known mental disorder, you can still use version 3 of the HCR-20. And the administration process, we now break down into 7 steps. So most of you who are familiar with the SPJ literature since about 2003 will be familiar with this. We talked about 6 stages, but in HCR version 3, we break down one of those stages into 2. So 7 steps or 7 stages. The first one, we gather information. Second, we determine the presence of risk factors. We go through our list of basic or standard risk factors. Next, we go through and look at the relevance of those risk factors. We try to consider which one of these risk factors is not only present, but seems to be relevant. It's functionally related to the perpetration of violence. And we do this factor by factor. And next, we develop a good formulation of violence risk. So this is like a multi-factor analysis of violence risk. So instead of the factors individually or one at a time, we now think about them working together. And then we switch and we start looking towards the future. Now that we've understood somebody's history of violence and what they've done in the past, we start to look towards the future. We say, now that I am educated by this patient's past violence, their history of psychological and social adjustment, what am I worried that this patient might do in the future? So this is what we call the scenario planning step. And we incorporate those elements of scenario planning methods that started to be developed in the RSVP and the SAM and so forth. After developing scenarios of violence, we then think about developing case management plan based on those scenarios. And then finally, we try to come up with some conclusory opinions to help us communicate our findings and opinions about violence risk. So those 7 basic steps. So let's just take a look at those in a little bit more detail. The first step for us is to gather information that's reasonably necessary to form an opinion. And pretty straightforward. We just want to make sure that we go about gathering the kinds of information that are typically considered relevant or important or necessary. Now, we always say we try to because it's not always available in every case. We always try to do an interview. But in some cases, we can't do an interview. In some instances, when we do work with the police, somebody's under investigation and they may not know it. So the police aren't able to do an interview with that fellow. Some of our patients and offenders refuse to speak to us, but we still have to do a risk assessment. Some people are willing to speak to us, but they may have an illness that makes it virtually impossible to communicate effectively with them. They may have disorganized speech or major intellectual disturbance that makes it impossible for them to participate fruitfully in an interview. And so we always try to interview people, but we may be unable to. We always try to look at records, but we may be unable to. If you're doing a violence risk assessment of a 25-year-old Somali refugee, you may have no information about criminal history or mental health background. You still have to try to do a violence risk assessment. Again, this is perfectly appropriate with the HCR-20 because what we say is it's all about understanding the uncertainty. And in those cases, we might have much greater uncertainty. The uncertainty may be so great that the outcome of the violence risk assessment is we have to say, I don't know. I can't tell you. I can't render an opinion with a reasonable degree of certainty. So the manual does contain recommendations about what kinds of information to gather and how to gather it. Once we gather the information, what we then do is we evaluate the standard risk factors, just like we did in the past, and Kevin will go through this in more detail in a little while. We've got 20 of them, so thankfully we didn't have to change the name to the HCR-23 or 16. What we've just done is we've taken all the information about a case and we've chunked it into 20 basic pieces. And we say, what's in that little category for us to look at? Is there any relevant information here? Is there evidence that this risk factor is present? And this is one of the things that the decision-making literature tells us is a good thing to do with human beings, is we don't leave information vague and abstract. We help people try to analyze the information. So if gathering the information is the synthesis, it's pulling all the information together, the second step is the analysis. It's to start to simplify it and chunk that information. 20 pieces of information, much easier for people to think about than a patient's life. Difficult to keep an entire life in your head, not so hard to keep 20 bits of information in your head. And of course, what's good for us is very rarely do patients have 20 risk factors. It's usually much fewer than that. They might have 5 or 10 or 15 of those basic risk factors present. We can also, of course, add in any other risk factors aside from the basic 20, which is a very important characteristic of the SPJ approach. We do not limit you. You can consider anything that you think is relevant about this case. You must justify it, but you can consider it. And just like past versions, these 20 items are broken into past, present, and future. 10 reflecting past adjustment right up until the present time, 5 looking at recent adjustment, and 5 looking into the future and thinking about anticipated adjustment in light of the person's plans and goals. So now we've had a little bit of analysis and trying to simplify our information base. By the time we get to the third step, what we're looking, I did say this, past, present, and future. And I will remind you as well that we can use the HCR-20 in 2 different ways. We can use the HCR-20 looking at ratings for institutional violence, violence in an institution like a prison or a hospital, or risk for violence in the community or upon release into the community. So you could do 2 different risk assessments for the same person on the same day. What if this person remains in hospital? What if this person is discharged? What's the risk to staff or other patients if we keep the person in the hospital? What's the risk to the public if we let the person into the community? And just like in the previous version of the HCR-20, we've got a simple 3-point coding scale. If you want to think about it as 3 points, we've got no, maybe, and yes, or no, possibly, or partially, and yes. Information indicates that the risk factor is present, possibly or partially present, or not present. And we just try to simplify it in this way because we think it's a good accountability mechanism. You should be able to reach a simple judgment about whether there's evidence that the risk factor is present or not. If you can't, then you've got a lot of uncertainty. That's bad. It's bad for you because you're trying to make a decision based on this information. And if important information is missing, and in fact we have to omit a risk factor, that's a difficult position to be in. But we must acknowledge that. We have to tell people that important information is missing, and then we have to be even more humble about the types of findings and opinions that we can render based on that information. And once we've gone through thinking about the presence of factors, then we think about relevance. And as we said, that's functional relevance with respect to the perpetration of violence and the management of violence risk. Does the risk factor make a difference? Based on your analysis of this person's history, can you find, for example, that their history of substance use appears to be linked to the perpetration of violence? Not surprisingly, in most cases it is, which is why, on average, substance use is a risk factor for violence. But all of us have run across cases where somebody has a history of violence that is actually unrelated to substance use. The person has a history of alcohol abuse, but when they perpetrate violence, it's when they're not drinking. It's after they stopped using alcohol. It's relatively rare, but it does happen. This is great for us. Now we've taken somebody's entire life, we've boiled it down into a small number of risk factors, somewhere up to about 20 or so, and now we're losing even more because we may find that some are not relevant. So we're shrinking the number of risk factors that we have to consider when we're developing plans. In the HCR-20, the way that we do this is by rating the relevance in terms of low, moderate, or high. Low means that the risk factor is not very, very relevant. Moderate means there's some evidence that it's relevant, and high means that it is relevant. And then step 4 is to now take those relevant risk factors, so the small number that are left over, it could be 3 or 5 or 10, and to develop a good multi-factor formulation of violence risk. And Carolyn will be talking about this this afternoon, and Professor Logan's written about this recently. This is, we think, one of the most important steps. This is where everybody needs to be heading. It's what we always tried to do well using our risk assessments, but in the past it's been unstructured. And we're trying to structure the entire process of risk assessment. So with the HCR-V3, we'll be trying to give you more guidance, but also more ability to do a good formulation. So we want a good multi-factor theory of violence risk. It's a theory for this individual. Now, a couple of things about this. We know that we always have a theory about a patient's violence risk. It can either be implicit or explicit. Those are really your only choices, yeah? Every time you see a patient who's got a history of violence, you cannot stop yourself from coming up with a theory about why this patient has been violent. That's what we are, right? We're meaning makers. We can't stop thinking in causal terms. So either you admit that and acknowledge it and try to make your thinking public so that you can take a look at it and see if the logic makes sense, or you can pretend you're not doing it. And our job is to try to make sure that you have the chance to bring that out and interrogate it and try to make sense of it. If it's implicit, you'll never be able to tell whether it's bunk or not. That's one thing about theories. You have to have them. It's just whether you're going to admit it to yourself or not. The second thing is nothing is so useful as a good theory, yeah? Nothing is so practical as a good theory. Because it's the theory that helps us develop good case management plans. So this is very important for us. It helps to figure out which treatments and which kinds of management strategies are most suitable for this person and how they should be sequenced and in what way they should be delivered. We need to have that theory. And then the third thing is all theories are wrong. The reason that we call them theories rather than reality is they're simplifications. They're always simplifications. We know ahead of time that it's not right. But what we're looking for is how correct or how close to reality it might be. As we have that ugly English word, the verisimilitude of it, the truthfulness of it, how close it approximates the truth. We want to be humble because we know we're wrong, but we need to have some kind of an idea in order to be able to act. So this formulation is very important. We have a number of approaches to formulation that we talk about in the version 3 manual. We are working on testing out several different approaches to formulation in different kinds of books and chapters and practice, and those things will be discussed in workshops coming up as well as the manual itself. So Carolyn will take us through a case example this afternoon. Next, step 5. We've come up with all our understanding of the patient's past. What they've done, why, we've had a good little think about that. Now we turn towards the future and we think about what are we worried this patient is going to do? And we focus on primary hazards or feared outcomes. What are my big ideas about what somebody might do in terms of perpetrating violence? If this person was going to commit violence, what would he do? To whom? When? Under what circumstances? Why? What would happen? And we have to have a think about that. The little description is called a scenario. And in keeping with the scenario planning literature, we usually try to think about little names for these things. With violence risk, it's fantastic because we have enough experience that there's really at least 4 scenarios that we should think about in every case. We always force ourselves to think about this. Is it possible that the patient might commit violence of this sort? The repeat scenario. Might he or she do again in the future any of the things that he or she did in the past? That could be one type of violence. It could be many types of violence. It might be that they have no history of violence. So there could be no repeat scenario, or there could be several. A twist scenario, could it be different? Might they do something in the future that's a little bit different than what they've done in the past? Could they be violent towards different kinds of victims, select the victims in a different way, or engage in violence in different procedures or for different motivations? Could we change the motivation or the topography of the act itself? Could it get worse? Could we have escalation? Could we have a worst case scenario where there's a homicide or life-threatening violence that maybe targets one or even multiple people? And then, really importantly, could we have improvement? Could it be that the person commits violence in the future that actually represents a reduction in risk? They're getting better. What they do in the future is less serious than what they've done in the past. Could we have a best case scenario where there's desistance? That's our job, is to work towards the improvement scenario. And in too much risk assessment, the focus is on the bad stuff. The bad stuff for us is what we want to avoid. The improvement scenario is what we want to make come true. That's what we want to invent, yeah? That's the future that we want to invent. So by thinking about these things and contrasting them, we can try to figure out what kinds of events or occurrences or interventions, what kinds of things we could do or that might happen would make one of these possible futures more likely or less likely. And we want to choose the things that make the improvement scenario more likely and avoid the things that make the other ones more likely. And the way I always put it is, a good map tells you where you're going. It's not a list of places that you don't want to go. A good risk management plan is not what to avoid, it's what to work towards. If your entire strategy for dealing with an offender is don't do this, don't do that, avoid this, it's not giving you much constructive to do. Nature abhors a vacuum, and human beings abhor behavioral vacuums. If you just tell people what not to do, it's not very good for them, right? It's like telling your kids, don't be noisy, don't run around. It's much better to focus them on what to do rather than tell them what not to do. We need to have a goal or a direction. A good map of how to drive from Edinburgh to Stirling is not to say, don't stop in Falkirk. Yeah, which is true, by the way, you don't want to stop. It's not a list of places that you want to avoid. It's a route to how to get where you want to be. So the scenario planning, we think, is critically important, but it needs to be guided by that formulation. And after we have those scenarios, now those little stories that we tell about how violence occurs are the stories that help us to prevent the violence. And that's where we can specify the management strategies and tactics and logistics that will help us to avoid the unwanted scenarios and achieve the good ones. So the words that we're using here, strategies, tactics, logistics, taken from the military because they're actually the people that do the best planning. For the last 100 plus years or so, we could probably credit militaries around the world with giving us some of the best ideas about how to try to do things well. So strategies for us is thinking about goals or objectives, what we're trying to accomplish. Tactics is how we're doing it, and logistics is how we support it. Strategies for risk management might include things like treating somebody's mental health problems. We want to improve their psychological functioning. We want to decrease the symptoms of a major mental illness like schizophrenia. Tactics, how are we going to do that? Medication? Which kind of medication? Do we want to have a cognitive behavioral program for psychosis? If so, which one? Where is it offered? How are we going to get that person in the group? How are we going to make sure that they get to the group? So now we're moving from strategies to tactics to logistics. And that's what makes a good plan. A plan that consists only of strategies is like saying, this man is a sex offender, he needs sex offender treatment, which is probably self-evident. What's really important is to figure out what kind of a treatment does he need, and is it available? And how do we make sure he gets to it? Is there a space available for him? Is it going to be appropriate? Is he willing to attend the treatment? So in version 3 of the HCR-20, we're really trying to force people to be more detailed about the plans that they develop. And then finally, we can think about, well, actually strategies. Our 4 basic strategies, of course, we have monitoring, supervision, treatment, and victim safety planning. Those are the 4 categories of strategies or groups of strategies that we talk about. And we always think that a good management plan should include strategies from each of these 4 domains. Wherever possible, we should have multiple strategies. So relying just on treatment, not a good idea. Relying just on supervision, restriction of freedoms. All you're going to do is keep somebody in prison for 10 years or in hospital for 5 years, because that'll help, right? That'll help to reduce the risk. We need to have something else to do, and we should have a nice balanced set of strategies. And very importantly, we include the victim in this, trying to deal with potential victims. And once we've done that thinking, then we're ready to go on to the final step, which is to communicate our critical opinions clearly and simply. And we encourage people to think about a number of primary issues, and they include things like, what's the risk for future violence, or as we sometimes call them, case prioritization ratings? How much effort or intervention is it going to take to try to keep this person from engaging in violence? Do any of the risks that we see for this person, the plausible futures, those scenarios that we think are actually worth considering, do any of those involve risk for life-threatening violence? Do any of them involve risk for imminent violence? And then finally, when are we going to need to review this case? Version 3, we're trying to push more and more that risk assessment is a process. It's a continuous process. It's not an event. It's not something that happens one day and then it's over with. And then you wait another 6 months or 2 years or 15 years and then you do another risk assessment. This should be a continuous process. Very easy to update a risk assessment. Doesn't mean you have to do the whole thing from scratch. It means you can actually just update it in light of new information or case developments. But very important for us to think ahead of time about the stale-by date for every risk assessment. When is it going to now be out of date? Should we wait 2 weeks, 2 months, 2 years? Give us an idea about how long you think we should wait, and then tell us what kinds of events or occurrences, what kinds of changes should trigger a new assessment. All right. What I'm going to do is end there and just take a little bit of an opportunity to try to deal with some questions.